Namaskar, dear viewers. Welcome to today's session of critical care webinars. And today we have a very special international faculty guest. He is Dr. Lorenzo Paul. He is from Genoa, Italy, and he is associate professor in anesthesia and intensive care at the University of Genoa. And he's been promoted recently from assistant professor to associate professor, and we extend our hearty congratulations to him. He's also an intensivist at intensive care unit of Poly Cliniclo San Martina Hospital, Genoa, Italy. And his area of research is lung imaging and mechanical ventilation. So it'll be really nice to hear from him because his area of research as such is lung imaging. So we thank you very much, Dr. Lorenzo Bolsa, for joining us. Thank you very much.
Thank you all for the presentation and of course for inviting me to give a speech on this topic I really enjoy talking about, which is the role of imaging in intensive care. Before starting, if you don't mind, if you want to participate to this quick interview, just to introduce the topic and see maybe also what you expect from this presentation, feel free to scan this QR code and I will ask you a couple of questions. The first one is, what is your first thought on lung imaging? If you think about lung imaging, what are you thinking about? First reply is chest X-ray. I somehow expected it. Of course, other techniques are possible. Chest X-ray again. Lung ultrasound. Of course, lung ultrasound is a trending topic in the field. We also have some other question and answer maybe on EIT, somehow expected. And if we want to move to the next question is, apart from what are your thoughts, which of these techniques do you really use in your clinical practice? Chest X-ray, CT, lung ultrasound. I'm not surprised. These are the most commonly employed techniques, and we will start from here, and we will discuss together a little bit about the role of evidence-based medicine and the issues of building intensive care medicine related EBM. And then we will talk about the role of imaging and in particular the role of functional imaging. So the numbers that we can take out of our imaging techniques. We will go through the topic talking about chest X-ray, CT, the assessment of lung recruitment, the role of lung perfusion. I will talk briefly about dual energy CT, which is a technique I've been recently studying on, and we will discuss the role of imaging techniques during the weaning phase, and we will try to understand which of these concepts can be translated in indications for changing our clinical practice of mechanical ventilation in particular. So let's start from EBM, and let's start from reasoning, facing the fact that building evidence in intensive care medicine is becoming difficult. We aim for randomized controlled trials. We all have been shown this pyramid of knowledge in which on top it's systematic reviews and meta-analysis, but the base on which systematic reviews and meta-analysis, which are those resulting in guidelines, recommendations, society statements, are mostly randomized controlled trials. A randomized controlled trial is a very simple but very powerful machine in which I take a population, I split it into groups. Typically, we have a control group and the treatment group, and we get a very easy answer. The answer can be yes or no. There is a difference between the two groups, or there is no difference between the two groups. What makes difficult applying this very simple but very powerful machines in the context of intensive care medicine is that the results of randomized trials depend also on how the hypothesis is formulated. For example, if I ask myself whether in a specific way of ventilating a patient is able to reduce the mortality by 50%, I might get the answer that if I randomize 500 patients, I get no as an answer. Why so? Probably because any treatment in the ICU is not really expected to reduce mortality by 50%. We would be, in many cases, be happy of having a treatment that reduces mortality by 5%. But the problem is that if I want to answer to the question, does my treatment reduce mortality by 5%? I have to randomize much more patients. And when I randomize many more patients, sometimes I get the answer I want, and I can demonstrate that that treatment is good enough to reduce mortality by 5%. The relationship between the number of patients that I have to randomize in an RCT trial and the expected mortality difference is illustrated in this plot. As you can see, if I start and we see on the x-axis the mortality in the intervention group, assuming that the control group is at 30%. If I want to reduce mortality from 30 to 20%, I already have to randomize 1,000 patients. But many of our 30%, for example, could be the mortality of sepsis, but do I really expect that a single treatment reduces mortality from 30 to 20%? Probably not. I would be happy to demonstrate that something reduces mortality from 30 to 25%. But in this case, I already have to randomize 5,000 patients, even more if I want to show smaller differences between groups. And building larger trials, it's time consuming, it costs a lot of money, and it's very difficult to apply in the field of intensive care medicine because we have very heterogeneous populations. Even if we think about one of the few syndromes or disease that really characterize our daily practice, such as sepsis and ARDS, these are not so common overall because we have many septic patients and many patients with respiratory failure, but the most severe forms are a relatively low percentage of all the patients admitted to the ICU. And within these groups, there are huge differences between, for example, an ARDS due to pneumonia or an ARDS related to septic shock. So randomizing patients supposes as a prerequisite that the study population is homogeneous, and this is not the case in many of our critically ill patients. That's why we talk about imaging. Imaging is much more related to physiology than to the strict rules of evidence-based medicine. We have very few randomized trials based on imaging, and we use imaging especially to better understand our patients. I don't want to discuss in terms of evidence-based versus physiology-based. I think this is the wrong discussion. I think that in the next years we will have the combination of the two, and the combination of the two is actually what we started calling personalized medicine, individualized treatment, individualized PEEP, if we think about mechanical ventilation. So imaging can help us in better characterizing our patient, and when we talk about imaging in intensive care, it's intrinsically functional imaging. Do you expect me to talk only about very sophisticated techniques such as electrical impedance tomography? No, I will not. The discussion will be much broader, and I will start discussing the research trends on PubMed. This is a snapshot that I took in 2021. It is a crucial moment of the history of critical care medicine. It was in the middle of the COVID-19 pandemic. You see that EIT, maybe the technique you would expect to grow more during the pandemic, actually stood quite stable during the pandemic. We had an explosion of studies based on CT scan during 2020. We had an explosion of studies doing lung ultrasound, using lung ultrasound, and even chest X-ray, a technique that we often consider a low level or no longer so important in contemporary era when thinking about the care of critically ill patients. It's actually witnessing a huge growth in what we can do with the images taken with a simple bedside chest X-ray. I mentioned before that I like talking about functional imaging. It's a naming that I brought or maybe have stolen from neurology, actually, because functional imaging is a term used to describe the methodologies that allow the function within the brain to be localized spatially or temporally during the examination. So we are thinking about advanced MRI or studies of cerebral perfusion, but we actually do the same also in the lungs and in our daily practice. It's in the instinct of the intensivist to have numbers because we apply protocols. We need to define how to ventilate our patients. So we usually aim not only for having the graphical depiction of what's going on inside our lungs, but we want to quantify. We want to study the evolution of the disease. We want to see how these numbers change according to how I set PEEP, to how I ventilate my patient. So I think that intrinsically, when imaging is in the hands of an intensivist, it becomes a functional rather than a morphological investigation. Thinking about the lungs, what can we measure? And we have to think about the fact that the structure, the anatomical structure of the lung, the function of the lungs, and what we get out from images are, of course, strictly connected. When we inspect the lung, we have to think about a gaseous compartment made up of alveolar gases, the gases trapped inside the airways. We have a solid compartment, which is parenchyma. We have a static liquid compartment, which is made by alveolar fluids, interstitial fluids, which do not move much during respiration, but we have dynamic liquid compartment, which is blood, which is moving fast throughout the pulmonary vessels, and it's a major determinant of the efficacy of blood gas in our patient. The idea of quantifying this phenomena is related to the concept of applying some kind of stimulus, which can be the X-rays, can be light, can be electrical current, can be ultrasound, and see some kind of reaction from the application of this stimuli. The idea of quantifying lung imaging is not new. This is a very old paper in which we are talking about chest X-ray. So chest X-ray is a paper from the 80s. It's a paper from 1984. I was born in that year, and in that year they were already studying the correlation between a score of the chest radiography, quantifying the amount of chest X-ray quadrants that were involved by opacification at the chest X-ray, and the amount of extravascular lung water measured with the double indicator thermodilution technique. What they saw in that study, apart from the nice correlation between extravascular lung water and the simple evaluation of chest X-ray, which is a very cheap technique that we still use nowadays, regardless of what we think about novel techniques. Chest X-ray, it's still there. But we see in this very early report of attempting to quantify imaging that imaging and lung function are strictly correlated, because one of the factors increasing the chest radiographic score, of course, it was hypoinflation. So atelectasis makes the lung more white and the score goes up. But on the other hand, in this paper, even if they do not discuss it quantitatively, they understood that how we ventilate the patient, how much PEEP we apply, it alters the opacity of the lungs. So even in this very early report, there was already some kind of concept of relating the function, how we interact with the patient, to what we get from imaging. So, talking about this very early paper, we can start from there. We can start from how do we quantify the extension of lesions and also the effects of what we do with our mechanical ventilation strategies, either invasive or non-invasive. And I would like to start from the good old chest X-ray. We should ask ourselves whether chest X-ray is really outdated. And the short answer is no. Look at this paper from JAMA Open. It is a case study in US hospitals. It's not necessarily reflecting the clinical practice in all the world, but it's important that in a super high income country as the US, chest X-ray were in the end of 2011, disencouraged by the American Society of Radiology, and nothing changed. The number of daily chest X-rays performed in the ICU was still high. At the beginning of 2014, there was another statement not to order chest X-rays exams at regular intervals, such as every day, but still people do a lot of chest X-ray. I'm not saying that we should perform a chest X-ray daily as we did 20 years ago, but there are still many centers that do a lot of chest X-rays. And can we quantify something also from the very simple chest X-ray? The answer is yes. It is an approach that I showed you already in the 80s, but a bit more recently at the beginning of the year 2002. This paper was published in which the size of the vascular pedicle of the lung, which is measured as you see there, dropping a perpendicular line from the point where the left subclavian artery exit to the aortic arch and crossing it with the line passing between the superior vena cava and the right mainstem bronchus. This simple number correlates very well with the amount of total blood volume. It's a sign of hyperperfusion and a sign of pulmonary edema. The correlation is very good. It's not complicated. It's just measuring two lines on the conventional chest X-ray, and we get already a very good information on how the patient is at risk of having fluid overload and pulmonary edema. Much more recently, in 2021, there was a study from a group in South Korea that investigated the capability of scoring with four different techniques. One was the simple visual assessment, so the classical radiological signs. One was the RAIL score. The RAIL score is being also now intensively studied in intensive care medicine. Is a score based on the division in four quadrants and giving a score to the intensity and the opacification. There are other scores, such as the Brixton score. The main difference is that it divides each lung in three rather than two portions. And there are increasingly used ways of estimating the percentage of the lung occupied by opacification. These techniques are becoming available also in the bedside chest X-ray scanners that we use every day in our units. Many of our radiologists and technicians do not know about these functions, but what is nice of this study is that it demonstrates it was a cohort of patients with COVID-19, as you expect, seeing that it was published in 2021. And the RAIL score, one of the four scores, was the one apparently performing better, in which a low score was associated with low mortality and high scores with a very high mortality. And you see that the discrimination between four classes of this score is very good. So simply looking at how white is my chest X-ray and trying to quantify it, not only stating this is a bit better than yesterday or worse than yesterday. Trying to give numbers to our chest X-ray allows us to understand which are which of our patients is at a higher risk of dying during the ICU stay. I already mentioned that the last method, so the estimation of the percentage of the amount of opacification in the chest X-ray, is made automatically in many of the contemporary machines we use to acquire chest X-rays at the bedside. But we have to look at the future, and the future probably is related to the development of artificial intelligence algorithms. And of course, this applies also to the analysis of very simple images, such as routinely acquired chest X-rays. There are attempts of building large data sets containing lots of chest X-rays to understand whether training neural networks and artificial intelligence will be able to discriminate between a normal scan, a scan with a suspected bacterial infection versus a suspected viral infection, or a suspected specific pathogen. In this case, again, was COVID-19, because many of the literature we had in the last years concerning lung imaging came from ARDS related to COVID-19. So let's move on to another much more sophisticated technique, which is computed tomography. We can consider it the gold standard for the three-dimensional assessment of lung aeration, so how the air is distributed inside the lungs. We all use it from a non-quantitative standpoint. We are very confident with this technique. Our radiologists are familiar with the diseases we treat in the ICU. And in this case, again, the stimulus we apply to the lungs is X-rays. The compartments that we are studying are the tissue, the fluids, and the air. We can get static information. We can get semi-dynamic information if we do repeated measurements, but this is time consuming. And if we want to quantify chest computed tomography, we have to move towards a bit more complicated approach. I will not go too much into the details. This is a very technical aspect of the analysis of computed tomography lung scans, but in one statement, we can say that lung CT can estimate the weight of the lung. Why so? You see on the x-axis, these are the CT numbers, so the Ansfield units. You will probably remember that -1000 is the density of air, and 0 is the density of water. So if we look at a normal individual, most of his lung parenchyma, if I select the lungs inside my CT scan, so I tell a computer, these are the lungs and this is all the rest, what I get is a huge peak in this area, around -800 to -700 Ansfield units. This is what is considered the normally aerated lung tissue. And in case of lung pathology, the blue line represents the distribution of density within the lungs of a patient with ARDS. We see that there is a huge peak around 0, because the lungs of a patient with ARDS are full of fluids and extravascular lung water, consolidation, which are all things that have a density very close to that of water. I will not show you the formulas, but the model on which we based the estimation of lung weight on CT is very simple. It's a model in which we assume that the air or the gases inside the lungs have no weight, while the tissue, the blood, the consolidation, the inflammatory cells, and so on, has a density very close to that of water. Of course, this is an approximation, but this has been validated several times, and it works pretty well. If we consider that each lung region is composed by a certain percentage of air and a certain percentage of lung tissue, blood, and so on, we can estimate the density of the lungs of our patient. more or less the density is 0.2 grams per milliliter in an healthy subject, so 1/5 of the weight of water, and the collapsed areas in ARDS or even in the atelectasis, if we think about a milder disease like the atelectasis that we see in postoperative patients, the density is 1, which is the density of water, 1 gram per milliliter. What have we thought studying the density of the lung based on chest computed tomography? One of the most important concepts we derived from this simple model was the concept of superimposed pressure. Most of our patients are lying supine in our ICU beds. If I take a patient with super healthy lungs, of course, this is the CT scan of a patient with almost no findings on the lungs. The most dorsal regions of the lungs will suffer a little bit from the compression due to the presence of a lot of lung parenchyma above the most dorsal regions. So if we measure the pressure inside the pleural cavity here or here, it will be different. But the magnitude of this difference in patients with healthy lung will be relatively small. Relatively small because the lung of non-injured patient has a density of more or less 0.2, as I mentioned before, and given the average diameter, ventrodorsal diameter in an adult patient, this results in a pressure around 3 centimeters of water, which is not much. It can cause collapse if the patient is resting in bed for a prolonged time. Think about the patient staying in a medical ward for several days before being admitted to the ICU. They will not have a clean CT scan of the lungs, even if they don't have lung pathology. But things change a lot when we think about superimposed pressure in patients with ARDS or in general pneumonia or any disease involving the lungs, because the size of the chest more or less remains the same. It probably becomes a bit smaller because of the hypoinflation of the lungs, but the tissue becomes much heavier because of edema, because of inflammatory cells, and in some cases also because of vascular congestion. So what was a gradient of 3 centimeters of water in healthy lungs becomes a gradient of 10 centimeters of water in the lungs of patients with ARDS. And this is important for 2 reasons. 10 centimeters of water are more than enough for closing the alveoli in the dorsal regions, and this is the reason why most of the collapse in ARDS patients is seen in the dorsal regions. The other issue is that 10 centimeters of water is a number which is in the order of magnitude of what we get and what we can modify with our ventilator. So if in an healthy patient, changing from 0 to 3 of PEEP probably doesn't change much. In ARDS, setting PEEP at 10 or at 20 or at 10 versus ZIP makes a huge difference. So we have to think about the fact that alveolar collapse, which is something we fight every day against in our patients, is mainly determined by this lung weight acting as a pressure in the dorsal regions of the lungs. And this has been studied a lot in ARDS patients and currently also in other populations. But another thing we can get from the CT scan analysis is the quantification of lung recruitment. This is a very famous study which has now like 2,000 citations. It's a paper by Luciano Gattinoni in 2006, published on the New England Journal of Medicine. And this paper studied the response to higher PEEP levels or higher airway pressures in patients with ARDS, and they identified that there are some patients in which applying a higher level of pressure. In this study, they did a CT scan applying a constant pressure of 5 or 45 centimeters of water, and this patient has a very heterogeneous and patchy pattern of ARDS, which if we apply high pressure, we result in huge recruitment of the lungs bilaterally. So this patient could be classified as a recruiter, and on the other hand, we have patients with the focal lesions that are predominantly located in the dorsal regions. This is the case of many pneumonia patients. If I apply a higher pressure, I do almost nothing to the collapsed regions of the lung because they are consolidated, and there's no PEEP level which is capable of reopening these heavily closed alveoli. And in this case, what we get is that the ventral region of the lung becomes more black. So we are just hyperinflating the ventral parts of the lung. I think that is very closely related to what we call now phenotypes. This is one of the first papers in which we tried to discriminate between the two entities inside the definition of ARDS. There are patients who respond to higher PEEP levels. There are patients who do not respond. So CT had taken at 2 PEEP levels, measured lung recruitment very precisely. And this brings us to the next topic, which is, in fact, lung recruitment. If we think about lung recruitment intuitively, I think that we all have this in mind. I have a patient with closed lung at a low pressure level. I increase somehow this pressure level, a recruitment maneuver, putting a higher PEEP level, and I want to get this lung, which is more open and more available to ventilation. We can discuss whether this should be done in all patients that have a potential to respond to PEEP, but this is another question. I want to focus on the concept of recruitment because it's strictly related to the history of imaging research in critically ill patients. Intuitively, we want to do that because we want to be more protective with our ventilation. We have the same patient before and after the application of an higher. This was not PEEP, actually, this was spontaneously breathing, so it was CPAP. And before we get this image, and we have this small portion of the lung which is available to mechanical ventilation. After the application of a higher CPAP level, this was the condition, and many regions of the lung that were before unavailable for ventilation, they become available. So one of the reasons why we want to recruit patients is that we redistribute ventilation on a larger portion of the lungs. This is very much studied in ARDS, but we know from animal studies, this is a very famous slide of a study conducted in the 90s on a horse, actually. It's a horse inside the CT scan. The only fact of inducing neuromuscular blockade and general anesthesia for intubating the animal and ventilating him induce dorsal collapse of respiratory units. And this has also been confirmed in patients undergoing general surgery. This is especially true for obese patients in which the collapse of the muscular tone due to NMDA use induces dorsal lung collapse. As you can see, this is a study we did with MRI. MRI is not normally used for clinical practice. It was a study especially funded for understanding the modifications in the lungs after induction of general anesthesia. We see a small portion of the lung, which is apparently small because visually it's only 6% of the volume. But if we measure the density, as we have learned before, so estimated that normally aerated lung is more or less 0.2 of density, and atelectasis is more or less the same density as water, we realize that this small region is actually 1/4 of the lung collapsing just for the fact of inducing neuromuscular blockade, intubating the patient, and subjecting them to mechanical ventilation. If we do a 3D reconstruction of the lungs, we see this is preoperatively, so nearly all the lung is ventilated or aerated correctly. If we induce the general anesthesia and mechanical ventilation, this is the scan of the same patient. You see that the lungs become much smaller, especially on the craniocaudal diameter due to the upward displacement of the diaphragm. And areas of the dorsal lungs start to collapse, and these are these red areas which represent atelectasis in our surgical patients. But in critically ill patients, how much pressure do I need to reopen the alveoli that are collapsed for the mechanism that we have discussed before? These are very famous slides from the group from Milan, in which we see that if we apply increasing pressure, we get more and more aeration in the lungs. If we want to achieve a completely open lung, which has been the idea of many researchers for a lot of time, we sometimes have to apply very high pressure. And this is, of course, not feasible for reasons that are not related to the behavior of the lungs, but to the fact that we are not treating the lungs, we are treating our patients. So, for example, the hemodynamic compromise of applying a pressure of 60 centimeters of water is probably always unacceptable. But one important thing is that the pressure that we need to open the alveoli is often very high. Sometimes we have to reach very high pressures, as we showed before. Many units open around 20 to 25 centimeters of water, but the pressure necessary to keep those alveoli opened, which is the closing pressure. So I inflate the lung, I do, for example, a recruitment maneuver, then I go back and I decrease with my pressure. The pressure I need to keep inside the alveoli to keep them open is much lower than the pressure necessary to open them. This is due to several mechanisms. And of course, we have to think about the fact that we ventilate the patient through one single tube. But when we use imaging techniques, we get informations on how ventilation is distributed regionally inside the lungs. If we inspect the lung in the ventral to dorsal region, we will have areas of normal aeration in which I need nearly no pressure to open them. I will have intermediate regions with a small airway collapse and other mechanisms leading to an opening pressure around 10 or 20 centimeters of water. I will have regions of complete alveolar collapse, necessitating pressures up to 30 centimeters of water. And then I will have consolidation, which can be dorsal, but for example, in bacterial pneumonia, can be also located heterogeneously, even in the ventral regions, we all know. And these regions, if they are consolidated, there is no pressure that will ever manage to reopen that. We have seen that CT is one technique that can measure very precisely at the regional level how the ventilation is distributed in response to a certain setting of the mechanical ventilator, but there are several techniques which are much more convenient that can be used at the bedside. We all know that lung ultrasound can see lung aeration. On the left side, we'll see a consolidation or C-type pattern, which is representative of total lung collapse. And if I apply PEEP, I can see regions in which aeration is restored. And this is an A pattern in which I see even not B lines, but just A lines, which are reflections of the pleural line. The group from Paris, it was a group of Puy Basset and collaborator, demonstrated that in addition to the visual inspection of the lung CT, we can quantify the amount of tissue that we recruit using lung ultrasound. They developed this score. For those of you that are interested, this paper is open access. You can reach it easily. And this author proposed a score in which each switch of pattern in the lung ultrasound in several lung regions was associated with a certain number of points. And they observed that there was a very good correlation between the lung ultrasound reaeration score and the PEEP-induced lung recruitment measured in milliliters using the multiple pressure volume curves method, which is one of the reference standards for recruitment measured by the ventilator. So we can not only visually inspect what happens in the lungs with lung ultrasound, but we can also see in detail and measure numerically what is going on in our patients. Another tool that is gaining increasing popularity is electrical impedance tomography. We use it in our unit, but I must confess that so far I still perceive it as a tool mostly used for research and in many cases not much available in the real world in several small hospitals or hospitals where there's no connection with the university and research activity. For those of you that don't know, this technique is basically based on the application of several electrodes around the chest. Commercially available devices do not require applying the electrodes one by one, but they developed electrode belts that can be applied around the thorax of a patient. A small electrical current is applied in sequence to these electrodes, and the conductivity from each connector to the others is measured. From this information, so how much the current is capable of passing through the thorax, we can understand the relative amount of air and tissues inside the lung. The concept is very easy. The air does not conduct electricity, while water and biological tissues do. So what we can get from these machines is in all machines we get this, which is a map of the distribution of ventilation. In most recent machines, we can also have an idea of lung perfusion, either based on the analysis of the electrical pulse related to the heart rate frequency, or in some case by injecting a saline bolus, which is used as a kind of contrast medium to study perfusion. So EIT recruitment is based on what I see in terms of changes of the distribution of aeration. This is a technique that applies an electrical stimulus that gives you a real-time image of the lungs. It has a very high temporal resolution. The image is built several times per second. We have to remember that the spatial resolution is relatively low, so the machines are capable to study the lungs divided in a grid of 32 by 32 pixel, which is very low as compared to the CT scan, but it can give information on recruitment and hyperinflation at the bedside without using ionizing radiation. One of the ways in which this technique was used is to study the effects of a decremental PEEP trial. We see in this image a decremental PEEP trial in which PEEP is decreased from a certain high PEEP, in this case was 24 centimeters of water, to low PEEP, in this case 6. You see that the overall impedance, so the amount of obstacle that the current finds to reach the electrodes in the belt decreases because the lung is deflating, and the small variations here, it's the tidal breathing over a certain level of PEEP. So the bottom line represents the PEEP level, the small changes represent the tidal breathing. What I can do with the EIT is tracking the amount of hyperinflated tissue, which of course decreasing PEEP decreases because I will have a lot of hyperinflation at 24 of PEEP and nearly no hyperinflation at a PEEP of 6 centimeters of water. On the other hand, I will have alveolar collapse, which will be very low at high PEEP levels, and it will go up at low PEEP levels. I can also study another parameter related to regional distribution of ventilation, which is called the global inhomogeneity index, which is a number proportional to the differences of ventilation of different lung areas within one section of the electrical impedance tomography. It is not yet demonstrated by large trials, but it's very intuitive that we probably want to set the PEEP around these values. We want to balance between hyperinflation and collapse. Several several protocols have been proposed, most of which suggest finding the intersection between the decreasing hyperinflation and the increasing collapse and setting the PEEP 2 centimeters above the crossing point to find the best compromise between collapse and hyperinflation. I just want to give one conclusive word concerning the concepts related to lung recruitment. When we apply PEEP levels, when we do recruitment maneuvers, we want from one side alveolar recruitment, but we sometimes have unwanted effects, such sort of virtual airway recruitment, so air that increases but in the airways and not in the alveoli, so an increase of that space. We can have an unwanted compression of the pulmonary capillaries, and we can have extrapulmonary effects. I'm thinking about effects on circulation, on the circulation of the kidneys, of the brain, and probably many other aspects that we don't think about. We have to keep in mind that we don't recruit the lungs, but we recruit our patients. And when we decide to set PEEP based on EIT, on lung ultrasound or CT or whatever, we have to keep in mind that the lungs are not the only things we are dealing with in critically ill patients. One of the things that are very often disregarded in clinical practice is the fact that lungs themselves require a perfusion. And this is a nice discussion between two authors, one of which I've been the pleasure to work with which is Joran Edenstierna. In this paper, Edenstierna stated, although the VQ abnormalities are often talked about in clinical management, there is no technique in routine clinical use to assess perfusion, even less at the bedside. So my personal comment was, therefore, nobody really cares about perfusion because we don't know what to do with perfusion. We don't know how to measure it at the bedside. But is it true that we can really ignore perfusion? The answer is no, and we have data also on that. This is a study conducted in 2021 by a group in Milan, in which the mismatch of ventilation and perfusion was measured using electrical impedance tomography. This group divided ARDS patients in two groups, the one on the left in which the red map is perfusion, the blue map is ventilation, and the gray area is where both perfusion and ventilation reach the lungs. And this is a patient with a large matched areas of the lungs, those receiving both ventilation and perfusion. On the right, you see a patient in which there are many areas in the ventral region which receive only tidal ventilation but no perfusion, and zone in the dorsal part of the lungs which receive only blood flow and not ventilation. These authors concluded that actually there was a difference in the amount of unmatched ventilation and perfusion between patient that survived in the ICU and patient who died, with a very good sensitivity and specificity, as you see by this ROC curve. But in the real life, assessing ventilation and perfusion mismatch is difficult. The only real bedside tool we have is electrical impedance tomography. But as I mentioned before, the option of measuring also the perfusion is more recent. Not all machines have it, and probably from a technical standpoint, we still have to understand a little bit more. I don't want to spend too much time. It is a very complicated topic, but I want to remember you that more or less we should think about the lungs as a model in which we have more or less 6 regions. We want all the lung to be here, so match the ventilation and perfusion. So any area of the lung which receives proportionally ventilation and perfusion will have preserved gas exchange. So on the right side, you will have an area receiving more ventilation than perfusion. If we go to the extreme situation of receiving only ventilation and no perfusion, you will have the true dead space. This will be the areas with increased VQ ratio, and in this case, there is a huge impairment of CO2 removal. And also, since these regions are not perfused, the blood flow and the cardiac output of the right heart will be diverted to our other regions of the lungs. And we know that in our patients, the lung is heterogeneous, so sometimes having a large TED space do not only affect CO2, as many of us are prone to think about, but also involves shifting the blood to more sick regions and potentially worsening also oxygenation. On the other hand, we have decreased BQ, in which we have venous admixture, to go also on this end to the extreme of having no ventilation at all at any level of perfusion, which is called shunt, and which is a heavy contributor of hypoxemia in our patients. There are regions which are probably larger than we expect in real life, which are neither ventilated nor perfused. We have seen it in COVID-19. These were the areas in which there was both viral damage and local thrombosis, which impaired so both ventilation and perfusion. And to some extent, the functional exclusion of these areas is similar to what happens when we do a lobectomy. When we take out a lobe of the lung, we isolate the bronchus, we isolate the pulmonary artery branch, and we take out that area of the lung from ventilation and perfusion. To some extent, this might be even protective in determining the gas exchange impairment in our patients, because after all, the fact that non-perfused, non-ventilated areas do not contribute at all to gas exchange, if they are not too large, is the reason why one person can survive after a lobectomy or a pneumonectomy. There are evolving techniques at the bedside. We have algorithms that are being implemented in the machines we use to acquire chest X-rays. So we go back to where we started from. We can acquire a continuous chest X-ray during a breath hold. So any change that we see in the chest X-ray is probably due to the change of the blood content, so perfusion. Then I reacquired the same CT scan, the same chest X-ray during dynamic ventilation, and changes in the chest X-ray in that case will be due to ventilation. So with some computer-based complex analysis, we can extract perfusion and ventilation images of the lung, and in the end obtain what we wanted, so a map of the distribution of ventilation and perfusion. You see this an example of pulmonary embolism in which this non-contrasted chest X-ray allowed to estimate the presence of 3 regions of the lung in which there was ventilation but not perfusion, and so probably due to pulmonary embolism involving 3 branches of the pulmonary artery. It could be a substitute at the bedside for the ventilation-perfusion scan, which at the medical school we are taught this is the gold standard for ventilation-perfusion assessment and for diagnosis of pulmonary embolism. But we all know that in real world, either we go for contrasted CT scan or we do nothing, because we don't really have a simple alternative at the bedside. I will conclude talking about a couple of topics. One is more focused on what I did on research, and this is dual energy CT scan. You might be surprised that the CT scanner you use in your clinical practice could have dual energy inside it, and even the radiologist could underuse it, because it is a technique that was thought to fill the gap between contrast-enhanced CT scan and the VQ scan doing with nuclear medicine. And the concept behind it, I always give this example. This is a picture of an airport. And this is a picture of an airport taken in black and white. Of course, we have much less information from a black and white image. And if you go through the security checks of an airport, you will see an image like this. And if you perform a black and white chest scan with an X-ray, you will get a black and white image. But actually, those of you that are frequent travelers will probably have noticed that security scanners give a color image. How is it possible? This is possible because the image is not acquired with a single energy of electrons, of photons coming from the X-ray tube, but the images are acquired with two energies at different levels. The subtraction analysis is actually a bit more complicated than that, can give you a color image also in the clinical practice. This is not used in chest X-rays much. This is much more commonly used in computed tomography. In computed tomography, in dual energy computed tomography scanners, two images are acquired simultaneously in one single scan. So there are two tubes inside the CT scanner, and it's much more common that you probably think. These are scanners that are available since nearly 15 years, and the images acquired at two different energy levels interact differently with the contrast medium. As a result, with a complex mathematical model, which I will not discuss, which is called the three-material decomposition, I can get a virtual non-contrast scan, so a scan 100% similar to the one we would have acquired if we did not inject the contrast medium, and as difference from the scan, the distribution of blood or iodinated contrast medium within the lungs. This has been demonstrated to be a good surrogate of lung perfusion. So we finally have a tool that can depict perfusion in the whole lung. We use it in our department, especially for complex cases. And as you can see, this is a 3D reconstruction of the distribution of blood in a patient with has a huge mediastinal mass compressing partially both the left artery and the left main bronchus, resulting in a very heterogeneous distribution of ventilation and perfusion with dead space areas and also areas acting as a shunt. Based on these images, we decided to intubate the right bronchus to let hypoxemic vasoconstriction act in the left side, and this allowed the patient to go safely to do the surgical removal of the mass. Two words about weaning. If we think about weaning, we think about the terminal phase of mechanical ventilation. We have already seen that lung ultrasound can estimate the aeration and the changes in aeration at the bedside. And concerning weaning, we have to remember that patients that have a high lung ultrasound score at the beginning and at the end of a spontaneous breathing trial are those at higher risk of failing the extubation attempt. This can be also seen more precisely with EIT. This is the mathematical definition of that global inhomogeneity index that I mentioned before. And also that inhomogeneity of ventilation is associated with extubation success versus failure. You see, a patient with an extubation failure has a very heterogeneous distribution of both ventilation and aeration and perfusion. And in case of an extubation success, the tidal image was much more evenly distributed, and the amount of inhomogeneity was very low. So higher inhomogeneity and loss of aeration are both associated with weaning failure. To conclude, I want to think about what we can do with all this complex information that come from each single technique that we have nowadays available at the bedside. And we already have attempted to conduct clinical trials in which we set the ventilator differently based on the pattern that we see on lung imaging. This is a very important trial. Actually, the main result of the study was negative. So if you look at the paper, the conclusion is that the personalized approach did not result in lower mortality, but the message is very important. Diffuse disease, application of high PEEP, focal dorsal disease, low PEEP, and early prone positioning. And from these Kaplan-Meier curves, you see that patients that were classified correctly, many of them were not classified correctly because not all the patients had a CT scan at the beginning of their course in the ICU, but those that could be correctly identified as focal or diffuse had lower mortality if treated with the personalized ventilation protocol. So we are studying this in many other ways, protocols based on lung ultrasound, and a protocol of mechanical ventilation based on lung imaging could improve the outcomes in ARDS. And I think, as I said at the beginning, that these years will be remembered as the era of personalized, individualized precision medicine, also in intensive care medicine. To conclude, I think that we started discussing about the difficult interplay between evidence-based medicine, physiology, non-randomized studies, randomized studies. I want to see it not necessarily as a pyramid, but more as a cycle. We study something, we test hypotheses using RCTs, and arising from the response we get from RCTs, we study a new physiology. And in the context of mechanical ventilation, the lung imaging is key to deliver personalized intensive care medicine and precision medicine in our patient. Thank you for your attention.
Thank you, Dr. Ball. That was just too good. It was like watching a movie. Fantastic presentation. Must congratulate you on the graphics and slide design apart from the content.
Thank you.
Can you just stop the share screen, Dr. Lorenzo?
Of course.
So request the audience if they have any questions. Meanwhile, Dr. Ball, I'll just put up a couple of questions for everybody's sake. We can just discuss a few things. So, first of all, just a little bit about clinical stuff. You see, there's this very big misconception that I've seen amongst our trainees and even some physicians that when we are treating a bad X-ray, whether it's ARDS or pulmonary edema, you should clear up with your treatment at the bedside within those many days itself, when you're giving the treatment. But the X-ray and even the CT does not clear up in many instances, right? It stays abnormal for quite some time, a couple of weeks, or maybe even more after the disease has gone, right? The pneumonia is gone or the pulmonary edema is gone. So if you can just elaborate on that, why is this so? Because this is a very big misconception, especially among the young people, that if the X-ray is not clearing, the pathology in the lung is not clearing.
This is a huge problem because I didn't discuss much throughout this lecture, but the timing of acquisition of images and the timing of reaction is crucial, of course. Whatever we do at the bedside, or even if we take the patient to the radiology facility, depicts what happens in the lungs exactly in that moment. It's the same as ECG. I can rule out myocardial infarction if I do an ECG now, but this doesn't mean that in 2 hours the patient will have a myocardial infarction. So if we want to integrate imaging with the clinical workout of our patient, we have to integrate information arising from different techniques, including those that can be easily repeated at the bedside. Lung ultrasound, EIT, for those that have these machines available, and even chest X-ray, remembering all the factors that influence what we see on the chest X-ray based on how we ventilate the patient and how is evolving the lung disease.
Dr. Lorenzo. So moving on to the first couple of slides that we are shown about estimation of extravascular lung water on chest X-ray. So,
Yes.
how do you actually do that? Because I've never used that. So, is it possible actually, or was that just a research study or something?
I think it's feasible. First of all, I would like to suggest you to check whether your chest X-ray machine is capable of automatically estimating the amount of opacity in your in your clinical practice, because this is already a good information. Of course, as any measure of extravascular lung water, it really depends also on how the patient is ventilated. In the same way, if I do the thermodilution before intubating a patient and then the thermodilution with the 15 of PEEP, the extravascular lung water will change, and the same will do the chest X-ray. But keeping this in mind, measuring the vascular pedicle width, which is the easiest measure, or computing the rail scores seems to be a reliable way to estimate the severity of disease and also extravascular lung water. Of course, in the chest X-ray, inflammatory lesions and water due to edema are both white. So we have to make also a correct diagnosis in the same way as we should not misinterpret extravascular lung water necessarily as edema when we do thermodilution. Is the same. But still, the message was that quantifying chest X-ray is feasible, and it is feasible even with very basic equipment, not necessarily with new or sophisticated machines or analysis.
So, if we can put numbers on this, can we kind of, has there been any study comparing this with the thermodilution methods, transpulmonary thermodilution estimation of extravascular lung water? Because then this is, we should look more into it probably, or, do more work on this, if is that feasible?
The studies have been conducted. To the best of my knowledge, these tend to be quite old studies. First of all, because thermodilution was much less available. So, 20 years ago, we were desperately in search of alternatives to estimate extravascular lung water without doing the thermodilution. But still, there are. I've recently reviewed a paper from a group in the Netherlands applying the RAIL score, which is an estimate of the severity of disease, including extravascular lung water, which is very interesting, and I hope you will see the
Right.
results
Okay.
soon.
So then, about the use of artificial intelligence. Again, you had shown a slide where probably we are working towards trying to, find the etiology of the pneumonia, whether it's viral or bacterial, just for an example. So do you think this is possible that AI will be able to sort out whether it's bacterial or viral? Because from what we know, this is practically not possible. What is taught classically, you cannot say the etiology of the pneumonia by looking at the X-ray or CT, barring a few instances, right? You see aspergilloma or something that's different.
Mm. Of course, there are. Let's focus on CT, which is much more precise in describing the topography of lung damage. We all know that we cannot make a microbiological diagnosis based on only a CT scan, but I think that many of us, many times, have thought and said in the clinical discussion, this CT looks very much like a pneumococcal disease, or this CT looks very much like pneumocystosis. Sometimes we were wrong, sometimes we were right. So there are patterns that are probably associated more or less with some disease. So far, we are not able to do any diagnosis, but I think this is a perfect field of application of artificial intelligence, because we already have seen in other fields that artificial intelligence is capable of seeing patterns even when the only human visual inspection is not able to discriminate between the patterns. And there are already successful applications, for example, in hemodynamic monitoring, where looking at the shape of the artery can predict hypotension. And I hope we will have some kind of help in this direction due to AI. I cannot say whether we will manage or not to achieve this result, but I think that it could be possible at least.
So just to take that forward, you are deeply into imaging. What possible outputs can we expect from AI in terms of imaging? Anything happening very soon, or is still some time to go?
I think that in the near future, we will see an explosion of attempts to use the emerging technologies to take out most we can from the images. The problem in intensive care medicine is that we are usually far mentally from radiology. There are already a lot of AI based protocols in radiology for diagnosing cancer, for finding lesions inside solid organs. We have much less concerning the changing physiology of patients receiving mechanical ventilation. So I expect that this will be years in which we will see a huge evolution in lung imaging, also in intensive care.
That's very nice. Wonderful. Thank you for the answer. Now, just a couple of final questions, Dr. Ball, about perfusion. You showed perfusion in the end. So now we have these patients, right, who are lying in the bed who have ARDS. And when we turn them over, perfusion is supposed to change, right, because of gravity. But the perfusion does not change, despite the change in gravity. Initially it was thought that perfusion would change when you make the patient prone, but the perfusion remains more in the dorsal area. So are we able to explain that any further? Because there was no explanation to that at least a year ago, as far as I know. And there were papers from Catinoni's group, sir. And what is your take on this now?
I'm afraid that perfusion is really the dark side of the moon when we talk about mechanical ventilation and respiratory failure in general, because it is way more complicated than ventilation distribution. It's more complicated to measure, especially at the bedside. And as you correctly stated, we had ideas that were contradicted by the following evidence. In particular, it is now almost established that prone positioning maybe acts improving the matching between ventilation and perfusion, but this happens mostly due to a distribution of ventilation rather than a redistribution of perfusion. And why that happens is very complicated. Just think about how few information we have on how drugs that we use every day affect pulmonary circulation. In the ICU, we use oxygen, which affects the tone of pulmonary vessels. We have patients with changing levels of CO2, which is known to affect lung perfusion, but we don't even know in which directions. There are animal studies suggesting that high CO2 is vasodilator in certain area of the lungs, and in some other is vasoconstricting. Then we have hypoxic pulmonary vasoconstriction and the effect of many drugs. We don't know much about the effects of noradrenaline, vasopressin, antihypertensive drugs we give to our patients. There are a lot of factors. It's a fascinating topic, but it's very complicated, and limited availability of techniques to assess the change of perfusion, especially at the bedside, it's a major challenge to improve our understanding of ventilation and perfusion.
Great. Thank you for the answer, Dr. Ball. Final question now. Just, because you are so deeply into imaging, we have seen the exponential growth of the sonography in the lungs, right? Lung ultrasound. So my question is, 6-7 years ago, really, we were not using sonography in the ICUs for the lungs, and we were doing with X-rays and CTs. Of course, they are still being used. Has there been any comparative study whether lung ultrasonography has made a difference in the ICU? Is there a proper study?
There are several studies, but this is one of the fields in which I see, this is a very personal opinion, a bit of discrepancy between what the literature says and what happens in the real world. I mean, we went through the phase in which we were told by the radiologist, you cannot study the lungs with ultrasound, it's impossible. We know that it's not the case, and we can get a lot of information from lung ultrasound, the diagnosis of pleural effusion, the diagnosis of pneumothorax, seeing whether a patient has dorsal consolidation or not. I'm a bit more skeptical about the real capability of avoiding all chest X-rays, as some experts suggest. And I also believe that things that clinicians believe in and find useful tend to affirm naturally in the clinical practice. It's more than 20 years that we are discussing about total avoidance of chest X-rays in the ICU thanks to lung ultrasound. For sure, we can reduce the use of chest X-rays using lung ultrasound in many contexts, but probably the initial ambition of eliminating chest X-rays from the ICU was an overreach of lung ultrasound. What is easy to do and meaningful for clinicians is already in use. I honestly don't expect that the scores that have been proposed for several years and that have now a limited use in the real world will be much more implemented in the next years. There are very specialized ICU in which lung ultrasound scores are taken even more than once per day, and this is perfectly good and very interesting. But sometimes we suffer understaffing, and thinking about doing lung ultrasound in the whole lungs to all the patients I'm taking care of, it's sometimes a bit unrealistic.
Right, sir.
Very personal opinion.
Okay, sir. Dr. Lorenzo Paul, thank you so much for all your detailed answers, sharing your experience and knowledge. And once again, the graphics, the slides were just beautiful. One of the best I've seen in real time.
Thank you.
And thank you so much. And I thank the audience.
Thank you.
For joining us. Thank you very much, dear audience. I hope you enjoyed it as much as I did. I found it really nice. Thank you very much, sir.
Thank you. Goodbye.
Bye-bye.